Folic acid deficiency anemia is another megablastic anemia or a macrocytic anemia. This is going to be where there's a deficiency in folic acid, so the blood cells are not going to be able to mature, so they're going to still be the immature, large red blood cells because folic acid is required for red blood cell maturation. So some of the causes is going to be chronically unnourished or malnourished patients. It's the most common cause. It's going to be poor dietary intake, especially foods that have green leafy vegetables, liver, citrus fruits. Patients, alcoholic patients, they have decreased absorption of folic acid. Patients who are anorexic, who are just not eating. Any condition where there's malabsorption through the jejunum, which folic acid is absorbed, celiac disease, or any type of inflammatory bowel disease like Crohn's, ulcerative colitis. Other additional causes includes drugs that impede absorption and the use of folic acid, methotrexate, which we know is an immunosuppressant, patients with inflammatory bowel disease, rheumatic, rheumatoid arthritis, autoimmune diseases are on methotrexate, patients who are on oral contraceptives, hormone therapy, and anti-seizure medications like Dilantin can impede the absorption of folic acid. Patients where there's an increased metabolic requirement, patients on hemodialysis, there's been found that folic acid is actually lost in the dialysis machine. Pregnant, lactating women, anybody where there's a rapid growth spurt, especially during childhood, there's going to be an increased metabolic requirement or demand for folic acid. Folic acid is only stored in very small quantities in our body, so if it's depleted, it's very quickly there's going to be a dietary deficiency because we don't really store folic acid long. We don't store folic acid as long as we do vitamin B12. So some of the manifestations of folic acid deficiency, they might be similar to vitamin B12 or iron deficiency anemia, where the onset could be gradual. So we might see a lot of general symptoms of anemia like the fatigue, the pallor, the dyspnea, especially if things get very severe. We're also going to see a lot of the GI symptoms that we see with iron deficiency anemia and B12, the anorexia, the weight loss, the diarrhea, the abdominal pain. We might see the pallor and the mild jaundice. We're also going to see the beefy red tongue, the sore tongue, that glossitis, and we're going to see the angular chelosis, that ulcerations around the corner of the mouth. The main difference between folic acid deficiency and B12 deficiency is that there's not going to be the neurologic symptoms. There's typically going to be neurologic symptoms with vitamin B12 deficiency where there's not going to be with folic acid, okay? Because vitamin B12 has a lot to do with myelination and axon impulse in the neuron activity, whereas folic acid does not. So some of the diagnostic findings, we're obviously going to see a decrease in folate level, but we're going to see a normal B12 level. Our CBC, we're going to see a decrease in hemoglobin and hematocrit. We're going to see a decrease in reticulocyte count, and that stems from, we know we need folate or folic acid for red blood cell formation. So if we're not going to have enough folate acid for red blood cells to mature, we're going to see decreased immature red blood cells. We might see a normal iron or total iron binding count or capacity, and we're going to see a positive gastric analysis for hydrochloric acid. And all this means is that we know that there's enough acid in the stomach that this is not a vitamin B12 deficiency, that this is a folic acid. So all of these tests are just pointing us in the right direction. So we just need to know too that we still have very little stores of folic acid and that the stores can be depleted very quickly in less than 4 weeks. So being that folic acid is water soluble, say it doesn't matter really, we can take a little bit more if we need to. So the typical standard dose is going to be 1 milligram per day by mouth. If they have to take IM, it's very comparable dose. If there's a malabsorption or a diarrhea state or Crohn's state or celiac disease state, they can take up to 5 milligrams per day. The duration of treatment is going to depend on the reason for the deficiency and prophylactic treatment in patients with higher needs. Like we said, because it's water soluble, it's better to err on the side of caution. We're going to encourage foods that contain large amounts of folate, like dark leafy greens, asparagus, broccoli, Brussels sprouts, and cauliflower. And we're going to try to avoid giving folic acid to patients with the corticosteroids, methotrexate, the oral contraceptives, the Dilantin, or the sulfonamides that can actually decrease the absorption of folic acid. So we're not going to give them at the same time. So in these patients who are on medications that can actually decrease the overall absorption of folic acid in the diet, we might prophylactically encourage higher doses in these patients. And we also might encourage at the same time to increase their intake of folic acid. So aplastic anemia is going to be a peripheral pancytopenia where there's going to be hypocellular or hypoplasia of the bone marrow, where there's actually going to be a decrease at the baseline foundation of your bone marrow, where there's not going to be any stem cell production of red blood cells, white blood cells, or platelets. So aplastic anemia can be divided into 2 main groups. It can be congenital or it can be acquired. Typically, your congenital obviously is going to be hereditary, caused by some sort of chromosomal alteration. Very rare cases, usually occurs in children. Their acquired aplastic anemia is going to be typically idiopathic, and it usually occurs in up to 75 to 80% of all your patients with aplastic anemia. So some of the causative agents, it could be from radiation, insecticides, chemicals, chemotherapy agents. One of the most common infections that can lead to aplastic anemia is hepatitis. A lot of prescribed medications can induce aplastic anemia, which there is a thought it is an autoimmune disease. Anti-seizure agents, certain antibiotics like amphotericin B, colchicine. So if it is a congenital condition, I don't expect you to know the congenital conditions, but in your Lewis textbook, there is a small box that does talk about some of the congenital conditions that are linked to aplastic anemia, but Fanconi anemia or Fanconi syndrome is one concurrent syndrome or disease that is linked to aplastic anemia. Again, I don't need you to know this, but it's just kind of helpful for you to put a link to the congenital or the hereditary. So some of the clinical manifestations, because like we said, there's complete loss of stem cell production at the bone marrow level of your hematopoietic stem cells. So you're not going to have the precursors or the red blood cells, the leukocytes or the white blood cells, or the thrombocytes. So you're at high risk for bleeding, high risk for infection in these patients. The onset can usually be insidious or it can be rapid, mild to severe, and there is a high mortality if left untreated, months. Symptoms are going to be related to the suppression by any or all of the bone marrow elements, and that term is referred to as pancytopenia. So in the event that somebody's anemic, we might see extreme fatigue, weakness, pallor, tachycardia, all those symptoms that we talked about in the beginning of anemia. In the event that somebody has a low platelet count, we're going to see bruising, abnormal bruising that occurs from just bumping your arm. We might see petechiae, gingival or bleeding of the gums, nosebleeds. In the event that a patient has a low white count, they could be neutropenic. The low neutrophil count, absolute neutrophil count significantly low, where we're going to be at risk for acquiring some of these very atypical common infections that our body normally can fight against. So we might have fever, we might have mouth pharyngeal ulcerations, we're going to have cervical lymphadenopathy, and then we might have an enlarged spleen. So some of the diagnostic studies that we might see for aplastic anemia is going to be a complete blood count. So we're going to see a decrease in their red blood cells, hemoglobin, hematocrit, low white count cell, especially a low neutrophil count, an ANC level, and we're going to see low platelets. If we checked a bleeding time or some of our coagulation factors, they might be prolonged. Because there's no hematopoietic stem cell proliferation, we're going to see a low immature red blood cell count. We're going to see increased serum iron because we have no hemoglobin to bind with the iron or for the iron to attach to. So we're going to have all of this excess or iron out free flowing in storage. So we're also going to see a key diagnostic test is going to be bone marrow aspiration and biopsy. And when we see it, we're going to see hypocellular with increased yellow marrow because there's going to be no red marrow because there's hypocellular. It's hypoplasia. So it's going to be crowded out by all that excess yellow marrow. So there's going to be numerous other abnormalities in the peripheral blood smears. And the picture on the right is a representation of a normal biopsy. We're looking at the bone marrow. And on the left, you can see where it's hypocellular with all the encroaching yellow marrow, the adipose. So what are we going to do for these patients with aplastic anemia? Well, obviously, if it's an acquired autoimmune, we're going to remove the causative agent. We are going to provide supportive and symptomatic care. That's what has actually prolonged the prognosis of patients with aplastic anemia. And that means utilizing blood products in severe cases, using antibiotics. There's different schools of thought. A lot of physicians want to use preventative antibiotics in these patients with low white counts, but then some doctors don't. They only want to use them in cases where there actually is an overt infection because we still worry about resistant antibiotics. Because the iron level is high because we don't have enough hemoglobin to bind to the iron, we're going to use iron binding agents because we know iron is a fat soluble and we can develop toxic levels of iron. It can build up in our organs, and so we want to make sure that we use chelating agents in the event that we have to give blood products in severe cases, especially because the blood products we use do have an iron content in them. So we're also going to use, because acquired anemia, aplastic anemia, we speculate is autoimmune, we're going to use immunosuppressant agents like cyclosporin, ATG. And so because these are immunosuppressant agents and we worry about opportunistic infections, atypical infections, side effects might include fever, chills. ATG can affect our T lymphocytes that can attack the bone marrow in these patients with aplastic anemia. So it's a very good immunosuppressant agent. Unfortunately, there has been some risks of rash, bronchospasm, and anaphylaxis. So in patients who are getting ATG, We need to be on the lookout for that. In some cases of aplastic anemia, hematopoietic growth factors such as synthetic erythropoietin or Procrit might be responsive, but it just depends on how severe the aplastic anemia is. If the disease is fairly extensive and way down deep into the bone marrow, they may not even be responsive to Procrit. We might use anti-neoplastic agents. In bone marrow transplant in younger patients who have an HLA antigen match are kind of gold standard treatments for aplastic anemia. So in patients with aplastic anemia, because they have impaired platelet function, thrombocytopenia, risk for bleeding, we don't want to utilize aspirin or Plavix in these patients. If patients have low ANC counts, they're neutropenic, they're high risk for infections, we want them to avoid raw meats, unpasteurized dairy products, and fresh fruits and vegetables. We want to make sure that they wear a medic alert bracelet. And for bleeding precautions, we want them to use an electric razor versus a straight soft toothbrush, avoiding alcohol because that can thin anticoagulate the blood even more, and we're going to avoid activities that could lead to injuries. So anemia nursing diagnoses and interventions. So one of the biggest intervention or diagnoses we're going to see with anemia is activity intolerance related to decreased hemoglobin and diminished oxygen carrying capacity. So we're going to encourage these patients to prioritize and space activities, balance activity and rest periods, assist with their activities of daily living. We're going to limit visitors and phone calls and interruptions by staffs. It's great for patients to have visitors, but we also know that when visitors are there, patients tend not to rest and they tend not to get what they need. We're going to assess their vitals, especially in the capacity if they have an infection. We suspect bleeding. We're going to monitor their lab values, CBC, their white count with differential, their platelet counts. And we're going to administer iron preps as ordered in the event that they're iron deficiency anemia. So alter nutrition, less than body requirements related to inadequate intake of essential nutrients. So we're going to collaborate with the dietitian. We're going to encourage patients to keep a food diary to keep track of what they're eating. We're going to first determine their food likes and dislikes. We want to make sure that they're eating in an appealing environment where there's not a lot of noxious stimulus, where it smells good, where it's a clean area. We're going to treat some of those mouth lesions because if they've got the sore, inflamed tongue, ulcerations around the corner, inflamed lips, they're not going to want to eat. And we're going to encourage small, frequent, and nutritionally sound meals. We're going to avoid alcohol because in a lot of nutrients, it decreases the absorption. Dietary supplements of iron, vitamin B12, and folate if applicable. So another diagnosis could be altered tissue perfusion related to inadequate blood volume or hemoglobin inadequate. In severe cases where their pulse ox or their oxygen concentration is low, we're going to give them supplemental oxygen. We're going to monitor their oxygen saturations and their vital signs. We're going to assess circulation. Are they pink? What's their temperature? Do they have peripheral pulses? And we're going to assess for changes in mentation. And when they're moving, we're going to help them move and enhance safety by changing positions slowly to prevent orthostatic changes. So impaired oral mucous membranes related to nutritional deficiencies of iron, folate, and B12. We're going to assess their gums daily. And we're going to use saline mouth rinse every 2 to 4 hours. We're going to make sure that they pay attention to oral hygiene before and after meals and at bedtime. And we're going to use a soft bristle to decrease inflammation and irritation. We might use a lubricant on their lips after oral care to prevent that inflammation in the chapped. And we're going to instruct patients to avoid hot, spicy, or acidic meals that could burn or that could increase the inflammation. We're going to encourage soft, cool, bland foods that are high in protein and vitamins. And especially in your patients that are at risk for the vitamin B12 deficiencies, they're at risk for injury related to inadequate blood volume, neurological manifestations. So we're going to assess their fall risks, assess for the paresthesias, the changes in the gait. We're going to look at changes for orthostatic hypotension. To prevent or enhance safety measures, we're going to keep the call light in reach, keep supplies close, keep them close to the nurse's station, utilize non-skid footwear if they're up. We're going to use assistive devices, and we're going to check on them frequently to make sure that we're meeting their needs. So primary polycythemia vera, or erythrocytosis, is going to be hypercellular bone marrow function of the myeloid stem cells. So aplastic anemia was hypocellular. Primary polycythemia vera is going to be hypercellular. So there's going to be an increase in red blood cell proliferation, okay, is predominant at the bone marrow. And we also could see white blood cell and platelet count increase, but they also have a shorter lifespan. Primary polycythemia vera is typically associated with a mutation of the JAK2 gene, okay? So this mutation doesn't allow our bone marrow to turn on or off the bone marrow production of myeloid stem cells. So the bone marrow is not responsive to any growth factors that are going to stimulate red blood cell formation or white cells or platelets. So typically, because there's going to be an increase in red blood cell formation, we're going to see splenomegaly in about 90% of these patients with primary polycythemia vera, because there's going to be increased congestion. And there's also going to be hypertrophy of the spleen because it's working overtime, eventually destroying all of these excess red cells. So eventually, because the bone marrow has become hypercellular, it's eventually going to start to burn out, resulting in the inability to produce cells. And over time, there has been research that's linked primary polycythemia vera to developments of leukemia later in life. And unfortunately, because some of the treatments that we use with polycythemia vera, the leukemia is actually refractory to the standard treatment. There is a secondary polycythemia. It's not considered polycythemia vera. It's a secondary, just polycythemia. And your patients who smoke, have advanced COPD, and live in higher altitudes like out west in Colorado, because of this chronic low oxygen level or hypoxia, they have elevated erythropoietin levels that are stimulated or released by the kidneys due to this hypoxic content. And it's going to stimulate red blood cell formation or production synthesis from the bone marrow. Patients with COPD who smoke, patients who live out in Colorado, they're typically going to have higher levels of red blood cell counts. And also, there are some secondary polycythemias from renal cyst or erythropoietin producing tumors. They can actually stimulate red blood cell production from the bone marrow. So some of the manifestations are going to be similar to the primary disease, except no splenomegaly. So some of the earlier manifestations are going to be overshadowed by the manifestations of the underlying disease. So some of the overall manifestations of polycythemia is going to be due to the increased blood volume and increased blood viscosity from all of these red cells. It's going to cluster the blood. There's going to be slow movement, slow flow, stasis, thickness. We're going to see congestion in the spleen. We're going to see a ruddy complexion from all of the increased red blood cells. We're going to see a headache. We have the potential to see blurred vision because of all of the increased pressure within the vasculature space. We might see increased blood pressure, chest pain, intermittent claudication to our lower extremities and to our upper extremities because we have such slow moving blood flow to our extremities. We might have, because of the venous stasis, we're going to be at risk for developing inflammation in thrombosis, thrombotic events that are going to lead to strokes, heart attacks. Because of the increased vasculature and increased blood flow and stretching of the skin, we could potentially see itching. We're going to see parathesias and mental status changes because slow flow. We're also going to potentially see bleeding complications. We're going to see petechiae, ecchymosis, epistaxis, portal hypertension, and this is because of the increased flow, increased pressure through the vasculature. We're also going to see epigastric complaints, fullness, early satisfaction with eating, and most of this is going to be related to the engorged organs. We might see weight loss, night sweats, and hyperuricemia. One of the byproducts of red blood cell destruction is going to be uric acid. So if we have increased red cells from this polycythemia, we're going to see increased uric acid, which can lead us to uric acid accumulation in the joints. So we might have gouty changes with people who have polycythemia. So some of the diagnostic tests we might see with polycythemia is going to be CBC. So we're obviously going to see an increased RBC, hemoglobin, and hematocrit counts. In patients who have primary polycythemia vera, we're going to see a low level in their erythropoietin level because this is a primary condition. The bone marrow is no longer responsive to growth factors. It just independently turns it on. Now, if we have a secondary polycythemia, typically the erythropoietin level that's released from our kidneys is going to be high because it's high secondary to chronic levels of hypoxia. So when we do bone marrow studies, aspiration biopsy, we're going to see hypercellularity at the bone marrow level of RBCs, white blood cell count, and platelets. We could do genetic testing to see if there's a JAK2 gene, which would be positive in most of our patients with primary polycythemia vera. So standard treatments with patients who have polycythemia is going to be phlebotomy or bloodletting. And this is going to be done to decrease the blood volume and blood viscosity and to reduce the overall blood volume. It's found to be very supportive and decrease some of the complications from thrombotic events, strokes, heart attacks. So typically at a treatment, you're going to see between 300 to 500 mLs of blood removed every 2 to 7 days until the hematocrit is at least less than 45%. And that's pretty standard across a lot of literature. So over the long term, these patients may need phlebotomy every 2 to 3 months. They may experience weakness and headache with the phlebotomy because we are removing 300 to 500 mLs. And if you think about it, a unit of blood is somewhere around 300 mLs. So we're removing quite a bit of volume with each time. We're going to instruct patients because they're at risk for vasovagal responses and hypotensions with this phlebotomy treatment to increase fluid the day before and 2 days after. We don't want them to get treated with iron because it's going to lead to an increased need for phlebotomy. So we know that iron is going to attach to hemoglobin and it's responsible for hemoglobin synthesis production. So we don't necessarily want to give these patients iron because it's going to increase our production of hemoglobin subsequent erythrocytes. So by giving iron, it's just going to increase our need for bloodletting or treatment. So other things that we're going to do to decrease viscosity and the risk of thrombotic events with polycythemia is encourage hydration and fluids. But since these patients are such high risk for hypertension and heart failure, we want to make sure that we closely monitor their intake and output. We don't want to give them too much fluids, enough to keep their blood thin or keep their low viscosity. We want to avoid tight, restrictive clothing to further reduce venous stasis. We want to encourage circulation, so we're going to encourage support hosts. We're going to ask them to avoid crossing their legs or dangling while they're sitting. We want them to engage in range of motion exercises and to increase ambulation because they're at big time risk for VTE or venous thromboembolisms or emboli. Other treatment to thin their blood, we're going to use platelet aggregation inhibitors or anticoagulants such as low-dose aspirin. And we want to also watch for gastrointestinal distress for bleeding with these patients. We might use something called agrelin, which is going to disrupt the maturation phase of megakaryocytes, which are immature platelets. So it's going to decrease the platelet production. So both decreasing the risk for thrombotic events. With agrelin, some of the side effects are going to be headache, fluid retention, cardiac dysrhythmias, diarrhea, and nausea. Because patients with polycythemia, because of the stretching of the skin, the increased flow, they're at increased risk for pruritus, especially aquatic pruritus. These patients have a lot of itching when they take hot baths or showers. So we need to encourage them to avoid hot baths and vigorously using a towel on the skin, drying out their skin. We want to encourage tepid baths with baking soda. They can use antihistamines like Benadryl to control the itching, but the most effective treatment has been known as interferon alpha. It is also used in the overall treatment for polycythemia as like a myelosuppressant, but it also has been linked to helping some of the symptoms like the pruritus or the itching. Because these patients are at risk for gout-like symptoms because there's an increased uric acid from the increased RBC production, these patients may need allopurinol to reduce the joint discomfort that might be from the accumulation of uric acid.